Hi, good evening, everyone. My name is Donna Gunkel. I am the Director of Clinical Integration at United Medical Accountable Care Organization. We do apologize for the slight delay in getting started this evening, but we want to go ahead and welcome everyone to our Wellness Wednesday webinar. And tonight we will be having someone join us by audio only. So we will get to that in just a moment. I'm going to see if I can. So the first thing we want to do is to welcome you and to introduce our entire wellness program team. First of all, we have Kamal Erkin. He is our chairman of the Accountable Care Organization and United Medical. He was not able to be with us this evening. Our program director for our diabetes and nutrition program is Dr. Rapu Hundal. He is an endocrinologist within our network. We also have Tim McHugh, a physical therapy with spine and orthopedics physical therapy, another one of our network providers. And we have Amy Wilcoxon, who is our program director of the dietitians. She is a registered dietitian and also a certified diabetes educator. And we have Jackie Tomasetti, our social worker. So we want to just give you an overview that at this time, twice a month, we meet to talk about diabetes, as well as we ask some of our specialists within the network from various specialties like endocrinology, cardiology. Tonight we have one of our nephrologists, podiatry, physical therapy, social work, and many others to join us and to talk about diabetes, as well as components from that particular specialist, that things that you can do in your program to live a longer, healthier, happier life. So I'm going to turn it over to Amy tonight. She is one of our panelists. She'll get us started with another welcome, and then she will turn it over to Dr. Patel from Nephrology Consultants to walk us through his presentation this evening.
Hi, good evening, everybody. Thank you, Donna. So as Donna said, twice a month on Wednesdays, we go through all the parts of diabetes, and because diabetes affects so many different parts of your body. So they are on our website if you haven't been able to see them before. And they're also on our Facebook page. So tonight, unfortunately, we can't see him. We have Dr. Patel with us, who's a nephrologist. And those of you with diabetes know that this is definitely a very important part of diabetes. So we're happy he's here with us to talk. And last week, I talked about our last session, I talked about heart healthy diet, which does go in with kidney health also. And tonight, I'm going to talk about another important part with the kidneys, which is a low salt diet. So I'm going to go ahead and turn it over to Dr. Patel. I'm sorry we can't see you, but thank you for joining us.
Dr. Patel, you are self-muted.
Can you hear me?
Yes, we can. Thank you.
Good evening, everyone. Thank you for having me. Would like to thank Kamal, Dana, Amy, all United Medical team for having me. And as Amy just mentioned, that diabetes affects many organs. And as a nephrologist, we take care of the diabetic kidney disease patients. Now, diabetes and the kidney disease is kind of very common. And the next slide, so basically my kind of agenda for kind of a meeting today, a couple of things I would like to focus on. Mainly why it's important to know about the diabetic kidney disease. In second part, we'll briefly talk about how do we screen it. Third part, what can we do to prevent the diabetic kidney disease? Or once we have a diabetic kidney disease, what can we do to prepare you so that we can control it or delay the diabetic kidney disease? Other point that I would like to cover briefly is what are the medications which would help in diabetic kidney disease? And the lastly, but more important, is that as a ACO, how we can help our patients take care of the diabetic kidney disease really well in terms of the evidence-based practice. So let's start with the first slide. It says number matters. Why it's important to know why diabetic is the leading cause of the chronic kidney disease and end-stage renal disease in the United States and worldwide. So prevalence of diabetes in the United States has increased over the last 20 years, now roughly about 10%. It used to be 5 to 6% before 5 years, but now it's up to 10%. Next slide, please. And unfortunately, despite we know that it's so prevalent to have a diabetic kidney disease, the awareness is extremely poor, whether it's among the patients or, for that matter, few of the providers also. The awareness is quite poor. And again, that's why it's important to have such a webinars, frequent meetings to create the awareness in the community about the diabetic kidney disease. Only 10% of the people with stage 3 CKD, chronic kidney disease, which is common, stage 3, is aware about their diagnosis. In the States, we have almost 60,000 people with end-stage renal disease. That means they are on dialysis because of the diabetes. And out of those 60,000, half of them, we think it's all because of the diabetic kidney disease. Next slide. Next slide. Okay. Thank you. So again, this is just the CDC data that more than 1 in 7 in the general population has the chronic kidney disease. Now, when it comes to the diabetes, approximately 1 in 3 adults with diabetes has the kidney disease. And when it comes to the blood pressure, 1 in 5 adults with high blood pressure has chronic kidney disease. Next slide. And as mentioned earlier, awareness is quite poor. Dana, can we have next slide, please? This is, again, it's from the USRDS data. Diabetic is almost 38% of the populations when it comes to the end-stage renal disease suffers from diabetes. Now, there are two kinds of diabetes. One is type 1 or insulin dependent. Another is type 2, is non-insulin dependent. Now, the basic etiology is that in type 1 diabetes, cells do not absorb the glucose in both type of diabetes, but in type 1, there is a deficiency of insulin. There is no insulin. So if you say that, those are the people who need, it's a juvenile diabetes or started at a younger age and starts insulin right away. Type 2 diabetes, well, there is an insulin, but because of other reason, cells do not respond to the insulin. In other words, patient has insulin resistance, mainly adult onset diabetes, where it starts from around 40 years of age, and obesity, high blood pressure, other comorbidities exist. Eventually, those patients start typically with the medication, oral medication, but down the road they will need insulin to cover that, to control their sugar real well. Next slide, please. So as a patient, what I really want to know is that what can my doctor do so that I know that how kidneys are getting affected from diabetes. So it's a very simple test. Your primary care doctor, your endocrine doctor does it. So it's a urine sample, random urinalysis, and they also check the urine for protein. So there are two tests. One is microalbumin, and one is the random protein creatinine ratio. Now, 24-hour urine protein, many doctors were doing it maybe before 15, 20 years, but now the data has changed, and even the random urine, meaning the spot urine test, is enough. No need for 24-hour urine. In blood work, BU and creatinine, those are the two numbers in the labs, in the blood work that tells us about the kidney disease. Now, it's very important, I think, overall, because unfortunately the chronic kidney disease is asymptomatic till the later stage. When you reach stage 5 chronic kidney disease, when you are about to start dialysis or when you need dialysis, that's when the symptoms of the kidney disease starts. So it's very common for the patients to say, well, my kidneys are fine because I don't have any symptoms. But unfortunately, these are the screening tests without the blood work, without the urine test. There's no way any doctor or patients can feel that they have kidney disease, because the symptom starts at a late disease. So it's a silent killer. Before symptom starts, the damage has been done. So only way to prevent, to know, is kind of being aware about the kidney disease and proactive, having every year urine sample, every year blood work, so that we can diagnose kidney disease in early stages. Next slide, Dana, please. So why do the kidney leaks glucose in the urine in diabetes? So why diabetes affects the kidney? So basically, kidneys are a filter. Like our refrigerator has a filter which cleans the blood. Same thing, kidney's job is to remove the waste product from the blood. Now, if there is too much of glucose in your body, in your blood, typically kidney filters are strong enough, kidney's blood vessels are strong enough to take that glucose, prevent the glucose to dump in the urine. Just because kidneys are a good filter, there are zillions and zillions of filters in the kidney, and that's what the function of the kidney is, to prevent all the waste, excessive glucose or excessive protein. It will not go to the urine, it stays in the blood, because kidneys are an effective filter. When you have type 2 diabetes or type 1 diabetes, over the period of months and years, your kidney filters or kidney blood vessels become leaky. And instead of the holding on to the glucose, instead of the holding on to the protein, it leaks in the urine. And that's how the glucose comes in the urine, and subsequently what we call diabetic nephropathy or diabetic kidney disease starts. Next slide, Dana, please. So similar concept, like glucose goes to the urine and subsequently protein leaks in the urine. And that's the first indicator. Protein in the urine is the first indicator of diabetic kidney disease. And only way to know is by random urine sample routine test. So as we see in this slide, most of the time kidneys are hold on to the protein, but when your blood vessels, your filters become leaky, it goes in the urine, and diabetic nephropathy or the kidney disease starts. Next slide, please. So in the micro level, basically the inflammation, the stress, oxidative stress, inflammation, fibrosis, those are basically, in the layman's word, if I have to say, it's scarring. Like if you have some infection, if you injure yourself, eventually after 2 weeks, the scar develops like a whitish scar. Similar concept in the kidney filters. Over the period of months and years of diabetes, it's caused stress, it caused fibrosis, inflammation, and subsequently your kidney filters become more scar and leaky, and that's how the diabetic kidney disease starts. Next slide, please. So diagnosis of diabetic kidney disease is simple urine test and the blood work, BU and creatinine. Now, typically the diabetic, recommendations is annual screening for the diabetic kidney disease. So if you have type 2 diabetes, whenever you diagnose with type 2 diabetes, that's the time you need to get the screen with the urine sample and the blood work for the diabetic kidney disease. Now, in type 1 diabetes, most of the time diabetic kidney disease lags behind for probably 5-10 years. So the current recommendations are that if you have type 1 diabetes, after 5 years of the diagnosis of type 1, you should get screened with the urine and the blood work for the diabetic kidney disease. Next slide, please. So there are three categories of the albumin protein in the urine. Less than 30 is normal. If it's 30 to 300, it's what we call is a microalbuminuria, means the protein in the urine is there, but it's like small particles. But if it's more than 300, that means you're spilling a lot of protein in the urine. And sometimes at this stage, patients do see some prody or the bubbles in the urine, and that's the early signs of the diabetic kidney disease. Next slide, please. So when it comes to the chronic kidney disease, there are 5 stages of the chronic kidney disease. Stage 1, when your kidney function is more than 90%. Stage 2 is when 60 to 90%. Stage 3 kidney disease, when your kidney function is between 30 to 60%. And stage 4, when your kidney function is between 15 to 30. And stage 5 is when kidney function is below 15% or when you're on dialysis. Now, these are the stages, but majority of the time when patient gets referred to the kidney doctor, they're already in stage 3, because stage 1 and 2, as I mentioned earlier, it's a very silent killer. If you don't recognize the protein in the urine early stages, stage 1 and 2 is already passed, because the elderly people already has a reduced kidney function. And now, because we are all living longer, life expectancy has been much higher compared to what it used to be before 20 years. We see stage 3 chronic kidney disease very common nowadays. Next slide, please. So how long does the disease take to progress? Most of the time, it takes years before you end up on the dialysis when you start diabetes. But what is important, if you have protein in the urine, now there are 2 slides here. The blue color is the protein in the urine. So if you have protein in the urine, your kidney disease progression is much higher compared to when you don't have protein in the urine or when you have less protein in the urine. So your kidney disease, typically, if you have a lot of protein in the urine, does progress between 5 to 10 years. But if you don't have protein in the urine, then your kidney disease, or when you reach stage 5, it takes 20, 25 years from the time of the diagnosis of the type 2 diabetes. Next slide, please. Blood pressure and diabetes is hand in hand. Blood pressure has been shown that if most of the diabetic patients, I would say 80 or 90% of the patient also suffers from the high blood pressure at the same time. So if you don't control the blood pressure, well, your kidney disease unfortunately is going to progress at a faster rate. And this slide typically shows that kidneys are happy when the blood pressure is quite under control compared to the unhappy kidney when your blood pressure is poorly controlled. Next slide. Next slide, please.
Hold on one second, sorry.
No problem. Yep. So
which one? I think I went back too far. I apologize.
No problem. I think risk factors is fine. I think
right
2
there?
slides back, a little back. Next. Yep. So the risk factor for diabetes, modifiable and non-modifiable. So what we can change is your blood pressure control, cholesterol control, weight reduction, obesity. If you're smoking, stop smoking, and A1C, which is important marker of the diabetic control. Those are the modifiable. Non-modifiable, where age, as you get older, your kidney disease is going to get progress. Male sex is more progress compared to the female. And ethnicity, unfortunately, African Americans, they do have more progression in kidney disease compared to the Caucasians counterpart. Next. Similar story, modifiable blood pressure control, lipid control, cholesterol control, smoking cessation, diabetes control, weight loss. Now, oral contraceptive pills directly does not cause the risk factor, but it causes high blood pressure and subsequently leads to kidney disease. Increased protein intake. So I just want to clarify, when I say increased protein intake, well, Amy is here, so I just want to clarify. Protein intake means that when we are talking about excessive protein supplement, like people, young generations now, we are using the creatine powder, muscle supplement when they are working out heavy. But the excessive muscle supplement or excessive protein supplement cause the progression of the chronic kidney disease. There is no need to restrict the protein in the diet when you have diabetic kidney disease. This is just to clarify, excessive protein is not useful, it's harmful. Next. So medication, what can we do? So unfortunately, there are not much medication when it comes to the diabetic kidney disease. So it's all about diet. So patients, when comes to me, that what can I do to prevent kidney disease? My recommendation is that the key is elephant in the room is diabetes. If you control diabetes, your half of the mystery is solved, and rest of the thing will fall on the kind of medication. ACE inhibitors, those are the medication which will prevent the progression of the kidney disease. Mainly, you may have heard about lisinopril, ramipril, or some angiotensin receptor blocker drugs like losartan, irbesartan, valsartan. Those are the medication controls the kidney disease and prevent the kidney disease progression. Next. So when you have a kidney disease, what precautions typically I do advise is do not take NSAIDs. That means non-steroidal anti-inflammatory drugs. So, stay away from long-term use of Aleve, Advil, Motrin, ibuprofen, naproxen. Those are the over-the-counter pain medication. It's better not to use. Some of the antibiotics, the Bactrim, many other antibiotics, ciprofloxacin in high dose is not good for the kidneys either. Now, when you go to fortunately, you don't have to go to the hospital, but if you do, I would recommend, if you have chronic kidney disease, tell your doctors that I do have chronic kidney disease, so they do not give you the test with the contrast when they give the CAT scan or any other angiogram or coronary angiography, cardiac cath or whatever. And educate patients about the native drugs, what kind of drugs you should be on when you have kidney disease, what can you not be on, or what dose adjustment needs to be done when you have kidney disease. And early referral to the nephrologist has been shown to improve the care in terms of the diabetic kidney disease. And patients who end up on dialysis and patients if started going to the nephrologist at an early stage, they do much better compared to patients with the later referrals to the nephrologist. Next slide, please. So glycemic goals. So this is just the pendulum that it's going back and forth, that what kind of A1C goals we would like to see in the diabetic kidney disease patient. And it's kind of an individualized goal. However, typically in older patients, less than 7.5 with few coexistent chronic illness, it's okay. We don't want to have too much rigid control in the elderly people because they can fall more with the low blood sugar and without much added benefit to their diabetic kidney disease. When it comes to younger patients, healthy without much comorbidities, our goal should be less than 6.5 A1C goal, provided it should not cause much hypoglycemia or low blood glucose episodes. Next slide, please. So this is what we call in the RAS inhibition. Basically, those are the drugs like lisinopril, losartan has been shown that it will reduce the protein in the urine. When we say that reduce the protein in the urine means less stress on the kidney, meaning that less scarring in the kidney filters. That means there is not much hard work for the kidneys. When you have diabetes, kidney works overtime to kind of controls or filters the glucose, filters the protein. When you use those kind of drugs like losartan, lisinopril, it would definitely help reducing the protein in the urine and reduces your progression of the chronic kidney disease. Number next. So typically these are the diabetic nephropathy. How can we manage? Lower blood pressure. Typically the goal is less than 130 or 80. Especially when you have protein in the urine, we are more rigid in terms of the blood pressure control compared to when you don't have protein in the urine. If you don't have protein in the urine, we are a little bit more liberal, less than 140 or 85. But if you have protein in the urine, less than 130, 80 is the goal. ACE inhibitors, lisinopril, losartan, titrate up to the maximum dose to reduce the protein in the urine. Better sugar control by A1C goal less than 6.5, and typically in majority of the patients 6.5 to 7. If you have cholesterol, our goal is less than 100. Use atorvastatin, any statin medication to bring down your cholesterol. When you have chronic kidney disease, you also become anemic. That's a part of advanced chronic kidney disease. When you hit stage 3, stage 4 chronic kidney disease, your hemoglobin drops. As a nephrologist, we kind of keep track of their hemoglobin. Our goal is to keep their blood count between 11 to 12. We sometimes give the iron, sometimes we give the shot called Procrit to keep the blood count up. Smoking cessation. If you don't have any bleeding problem, aspirin daily helps preventing the kidney disease progression. Number next. So metformin, I just want to, few slides about the medication, because I see often that patient feels that metformin is killing my kidney. I just want to educate everyone that metformin is a good drug to control the diabetes. And nowadays in 2016, FDA has changed the labels, because initially the cutoff for metformin was almost like 65% or so, meaning GFR, or percentage of your kidney function, falls below 65, they would advise not to use metformin. But nowadays, it's okay to use till 45%. And metformin is a good drug. Endocrine people love metformin. It's cheaper, readily available. So now change is 45 cutoff. So no need to change metformin if you're on till your GFR or the percentage drops below 45. Next slide, please. So blood pressure goes, as I mentioned earlier, it's a pendulum, but typically 130 or 80 if you have protein in the urine, and diabetic kidney disease, if you do not have protein in the urine, 140, 90 is acceptable. Next. So this is one slide I really want to show, because these are the new medication came in the market before a couple of years, but in lately it has been shown as it has changed the diabetic kidney disease management from, drastically. Initially, when this kind of drugs, to name is like, it's called Invokana or Jardiance, those are the medication came in the market before a couple of years. And as a nephrologist, we were stopping all those medications because we felt that that was causing the kidney disease. But surprisingly, more and more data is coming in last 6 months or year. Now, actually, we are the one who's recommending this medication, because more and more studies coming out that these are the medication helps the kidney disease. It helps reducing the heart failure. It helps reducing the heart attack. It helps reducing the progression of the chronic kidney disease. Patients who are on this kind of medication, their kidney disease or their time to dialysis has been significantly low. From stage 3 intervals to stage 5 progression has been considerably low. Even those medication has been shown to reduce the protein in the urine. So talk to your primary doctors, talk to your endocrine doctors. These are the new medications. It's Jardiance or Invokana, newer medication, but has shown significantly, it has changed the management of the diabetic kidney disease dramatically in last 6 months or so. Next slide. So these are, I'm not going to go in details. These are the same trials just published in the New England Journal of Medicine, one of the reputed journal in the medicine, that it does improve the prognosis. It prevents the heart attack, prevents the heart failure, prevents the diabetic kidney disease progression. And next slide, next slide. Next. I'm not going to go in detail of this. Next. 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 Yep. So briefly, what I really want to talk about, why it's important to be a part of the ACO when it comes to the management of the diabetic kidney disease. First of all, care coordination. It's easy to communicate between the primary care doctors. The patients are the center of universe here. The primary care physicians, their endocrine who's managing their sugar, nephrologist who's managing their diabetic kidney disease. So drug-to-drug interaction is important. How diabetic doctor chooses the drug, the new medicines, like, we closely work with Dr. Hundal and, other endocrine to guide the patients and kind of make a collective decision that what would be the better approach for the patient in terms of the choosing the right medication, so that we can control the sugar as well as control the diabetic kidney disease. It's like hitting the two birds with one stone. Dietitian, as a part of ACO, Amy is doing a fantastic job. I have referred many patients to her. And, because at the end of the day, diabetes is the elephant in the room. Better the diabetes, better the kidney disease control. We share the EMR, so it's easy to communicate from one provider to other providers. And it's easy communication among the providers, and also, the IQ Health portal. It's easy for the patients to communicate with their providers too. It has been shown to lower the cost. We choose the drugs which is affordable and effective. And we do practice evidence-based medicines, so better outcome when it comes to part of the ACO. What is more important is that it's easy to coordinate. Once you are in the hospital, we give you the follow-up soon so that we can adjust your medication. Whatever the medication which we think is harmful to the kidneys or diabetes, we can eliminate that medicines quickly. Post-discharge follow-ups, in timely manner. So there is a lot of advantage as a patient to be a part of the ACO, because it's just kind of a easy coordination of the care and better outcome. I'll take the questions. Thank you.
I do have a question, Dr. Patel. How soon do you want to see a patient with diabetes? So if you have somebody whose BUN creatinine is it's not too elevated, but they have high blood sugar, or I'm sorry, high blood pressure, do you want to see them then, or do you want to wait until they're up into stage 2?
Right. So typically the current recommendation is the protein in the urine. So if patient has proteinuria at any stage, that gives them a stage 1 kidney disease. Having even the GFR is normal, even the creatinine is normal. If they have proteinuria, it's recommended that patient be seen by the nephrologist. Now, if other indication is if their blood pressure is difficult to control, even without protein in the urine, because at the end of the day, diabetes and blood pressure is kind of, both works hand in hand. So those are the other indications. But absolutely, if GFR is abnormal less than 60, or if the creatinine is more than 1.2, those are other indications for the referring to the nephrologist.
Okay, thank you.
And I just had one follow-up question to a lot of that about the protein in the urine. So I know you had mentioned earlier about patients making sure that they have that urinalysis done annually. So I just wanted to kind of put a plug in there that if their PCP does not order that they should be making sure that they're asking or keeping track, it sounds like, of when they had their last urinalysis, and then making sure when it's ordered that they get that done timely, right? And that they discuss those results with their primary care doctor.
Yes, Nana, absolutely. I think it's this is the kind of important thing to create the awareness among the patients so that they can take the initiative, because I'm sure primary care are busy. So it's always good idea to have them order the urinalysis. And urinalysis is simple, and there's not much cost. If I believe it's $4 or $5, because it's a simple dipstick. You don't have to have like a fancy test to start for the screening purpose. And when you have diabetes, it's recommended that annually they should have the urinalysis, at least for the patient with diabetes, though.
Thank you.
Thank you.
All right, so we're going to turn it back over to Amy. If there are any more questions that come in, certainly we can ask those at the end for Dr. Patel. And now Amy's going to talk to us about some tips with regards to diet that pertain to your kidney health.
All right, and I want to thank Dr. Patel for making that plug that protein does not have to stay in a pedestal. It's the everybody's favorite nutrient these days, and we know that excess protein is not a good thing.
All right.
Because people think you can't do anything wrong with protein. So I think I should put that on my list for next month too to talk about. But today we're going to talk about salt. So I have a lot of my patients, as Dr. Patel can imagine, and Donna knows, have come to me with high blood pressure and obviously diabetes. So, and I say to them, are you watching your sodium? And they say, well, nobody told me to do that. And there's a lot that it goes over in doctor's visits. So perhaps that's somewhat slips their mind, even though I think it's been discussed. So a little reminder of what we're looking at for a low sodium diet. So the first thing is to know what contains sodium. The majority of American sodium intake actually comes from packaged foods. Salt by itself that you add is a lot of sodium, but we eat a lot of cookies and crackers, instant oatmeal. So oatmeal in the container has no sodium, but instant oatmeal, like maple and brown sugar in the packet, has 200 milligrams, 170 milligrams of sodium. Bread, spaghetti sauce, box noodles, so think about ramen or macaroni and cheese, or the Knorr noodles and side dishes, potato mixes like the potato buds or flakes, anything frozen like a lean cuisine or a Stouffer's frozen meal, certainly snack foods like potato chips, pretzels, frozen desserts, chips, popcorn, granola bars, lunch meat, cheese. The list goes on and on and on. So what doesn't have sodium is probably a much shorter list. So fresh meats, even some fresh meats, pork products are often injected with sodium to make them more tender. Fruits and vegetables, no sodium. Eggs, no sodium. So the list keeps going on. Salt, a teaspoon, a measured teaspoon, so not a teaspoon you eat with, but a very small one, is 2,300 milligrams of sodium, which is the upper limit for everybody. But if you have kidney disease, then you need even less than that. And the statistics are all over the place that average Americans eat anywhere between 4,000 and 6,000 milligrams a day. So more sources on there: condiments, barbecue sauce, ketchup, mustard. Salad dressings are high. Soup is very high, canned soup, broth. And then anything in a can typically has salt added. So canned vegetables, tuna, pastas, chilies, etc. Next slide, please. Thank you. So tips, how do you cut back on your salt? The first thing is remember that teaspoon of sodium, or a teaspoon of salt. So don't put the salt shaker on the table. Put it away. This is a hard thing. Americans really like salt. They've studied the brain. They know that we like salt and we like sugar and we like fat. So think about some of your favorite foods like French fries and hamburgers. If they're not sweet and fatty, they're salty and fatty. So that's the flavor that we crave. A lot of our foods, think about the most popular sort of American foods, think about pizza and hamburgers, they're all really salty. So you have to retrain your taste. If you're used to eating a lot of salt and you eat an unsalted dish, it's not going to taste good to you. So you have to wean off of it. Learn to cook with herbs and spices, so garlic and rosemary and basil. And then read your labels. So if I pick up a package, if I'm going to have Cheerios for breakfast, I can look to see how much sodium is in it. So I know I can have 1,500 milligrams a day. This is 190 milligrams, so it's not very high in a cup and a half, so which is a decent size. So looking at that to see what do I have that's high in sodium. So the limit is, as I mentioned earlier, under 2,400, but then if you have kidney disease, heart disease, some other conditions, the recommendation is 1,500 milligrams a day. When I worked in a hospital, we never put anybody on 1,500, it was 2,000, under 2,000, because 1,500 was considered to be very challenging for people. So it is hard to come off of that. Can I have the next slide, please? Thank you. So reading a food label, I jumped a little bit ahead. So if you think about how much you can have per day, you want to break it up. It is a per day thing, but it's hard to have it all at once. So if you look at the label on here, you'll see two numbers next to sodium. You'll see a number in milligrams and you'll see a percentage. So the percentage on this slide is circled on that label. It's 37%. That's very high. If it's less than 5%, it is considered a low sodium food. This is 890 milligrams, so that's pretty high. That's a lot of salt at once. And you can read, it tells you it's soup, it's chicken noodle soup. So canned soup, condensed soup is very high in salt. They make reduced sodium soup. Note that reduced is not low sodium. So it has to be less than 5% of the daily value to be labeled low sodium. And we don't see low sodium potato chips. We do see reduced sodium potato chips, typically things like that. So look at the labels, and then once you find something that you like that's low sodium, pay attention to it, write it down, because you might find other brands and they're not as good. So make sure you always read the labels when you're shopping for sodium. Next slide, please. So the DASH diet is dietary approaches to stopping hypertension. It's been around for a long time. It's actually the way we're all supposed to be eating. It's similar to a Mediterranean diet. And it's very good for people with diabetic kidney disease or diabetes in general without the kidney disease. So what it involves is increasing portions of high potassium foods. So healthy foods like fruits, vegetables, unsalted nuts, beans or legumes, and low-fat dairy. And then you decrease your servings of processed food and salt. So if you think about maybe the way your grandparents, your great-grandparents ate whole foods, natural foods, so you might be eating a sweet potato or roasted potatoes instead of French fries. You may be eating fresh meat or beans or fish instead of a hamburger. So think about it that way, and vegetables. So eating more whole foods. Next slide, please. So this is hard to read. Hopefully on the home it's a little bit easier. So this is an 1,800 to 2,000 calorie DASH diet plan. You may need less calories than that, so your servings would go down. So you can see that grains, and you may think, well, I can't have that many grains, I have diabetes. But if you're choosing healthy whole grains, like oats, they certainly fit in there. They're higher in potassium. The less processed it is, the more potassium it is, the less sodium it is. The more processed it is, you lose the potassium, you gain the sodium. So you see vegetables are on there, fruits, dairies, meats, there's not a lot of. So it is a very particular plan you can follow. This is from NIH. So DASH is online. It's easy to find. It's not easy to follow if you eat a lot of fast food and frozen food. So it does take some time, but if you can gradually eat 1 or 2 meals a day like this, even that little bit is going to help you. Next slide, please. So final nutrition thoughts. Keep an eye on your sodium intake. Make sure that you're eating whole grains. Again, the minimally processed carbohydrates are going to be better for you. They're going to have less salt. Fast food is one of the biggest problems we see with diabetes, with heart disease, kidney disease. You've got a lot of fat, you've got a lot of salt. Processed meat, so think about lunch meat, is a lot of sodium. So eating 2 to 3 cups or 2 to 3 servings of fruit, 3 to 4 vegetables will help you. And I should also add in there drinking a lot of water. The reason why we talk about sodium is it's hard on your kidneys. It takes a lot of work. And then if you're not having a lot of water, you're not flushing them out. So stay hydrated as part of the last one. So not just reducing sodium, but also increasing water intake. Sometimes we do see patients, and if you're listening and you're in a later stage of kidney disease, sometimes this does cause confusion because people will say, well, I can't have anything healthy. I can't have whole grains and I can't have fruits and I can't have vegetables because I have high potassium. So you can, but there is a limit. So it's important that you go see a dietitian because we can help you with this. Some people say, well, I can't eat anything, so I just give up. But in later stages in dialysis, there's a dietitian there that sees you. And we are here to see people to help with any sort of restrictions, whether it's potassium, phosphorus, or sodium. So ask your nephrologist about coming to see us if you need help with food. That's what we're here for. So any questions for me? And thank you.
So Amy, I have a question. And you touched on it a little bit earlier, but I didn't know if maybe you could expound on it a little bit. I think sometimes, and I'm probably guilty of that as well, looking at food labels, you know, sometimes we feel like we want to focus in on just one thing, right? So if we're like, I want to reduce my calories, then I feel like I just want to focus on the calories. But if I heard you correctly, you want to focus on more than that. So you want to take a lot of those things into account when you're looking at that label of looking at not only the calories, but maybe the amount of carbohydrates as well as the amount of sodium. So do you want to talk a little bit about kind of like looking at all components of the label?
So it's a challenging, and it can take a long time in the grocery store. So when you're looking at a label, you may, if you're trying to lose weight, you might be focusing on calories, but I could be eating a sugar-free popsicle and that's going to have less calories than an apple. But clearly the apple is the better choice because it has nutrition in it, no label to read, but it has the better nutrition. If I'm taking insulin based on carbohydrates, I have to count my carbs. If I'm watching my salt, I have to look at sodium. So knowing what you need to look at. If I'm looking at a label with somebody who doesn't have diabetes or high blood pressure, let's pick a different box. So we'll look at this bean pasta. So I'm looking at this, I might think, okay, so I know pasta is mainly carbohydrate. And this is made out, oh, there we go, red lentils. So does this have the carbohydrates? Okay, 34 grams. Pasta is about 42, wheat pasta, but it has 13 grams of protein and it has 6 grams of fiber. I could compare it to a box of wheat pasta to see the difference. So I can look at, and I think when you're looking at a label, it depends on what kind of food you're looking at. So for pasta, this is fiber and protein. So it's something, and this is something a dietitian can help you. But it goes back into that with DASH, sort of the basic. Think about the foods that were really high in the DASH diet. Fresh seafood, unsalted nuts, fruits and vegetables. They don't have labels. So, I mean, think about it that way. When we know we're eating those whole real foods, you're not going to have to focus so much on a label. We're not looking at a label necessarily to see what's in the apple because it doesn't have one. What you can do that's helpful is compare foods of the same product. So you can see, you know, this one, let's see, this one doesn't have any fiber and this one does. So looking to see which is the better choice for you out of what you like. So hopefully that helps clear that up. I could do a whole
Yes.
hour on food labels.
I know, but thank you. I think sometimes expounding on it a little bit helps to clarify. I know we run through a lot of information very quickly. I do want to thank both Dr. Patel and Amy for the great discussion this evening about low salt diets and kidney health. Are there any last comments that you would like to make, Dr. Patel?
No, I think thank you for arranging this, because at the end of the day, what matters is that, education of the patients, providers, and having more awareness about the kidney disease and diet choice, because, it's all about prevention. And when it comes to diabetic kidney disease, it's all about prevention. Prevention is better than cure and can be more truthful when it comes to diabetic kidney disease. But thank you.
Great, thank
Yeah.
you. And we will be back in 2 weeks on October 28th for our next wellness webinar on Wednesday. And Amy, what do we have up for our next session?
We have Dr. Hundal, our endocrinologist, will be back again. He's going to talk about medication, and I know a lot of people have questions. I love that Dr. Patel, you commented on metformin, one of my favorite medications, that it's safe and it's a good drug. It's that I always tell people we used it with kids when I worked in pediatrics. It's been around for a long time. He's going to talk about all the different classes of medications and what the different classes do. And then we have Celeste, a diabetes nurse educator, who's going to talk about the different devices. What is continuous glucose monitoring? What does it do? Do you want one? Do you want a pump? Why should you use a meter? What features do you want to know about on your blood sugar meter? So for people into devices, medication, it should be a lot of good information. And that's October 28th, as Donna said.
Thank you. All right, well, we want to thank everyone again for joining us tonight, and we hope that you join us in 2 weeks for our next session. Thank you all.
Thank you.
Thank you.